Hi, everyone. My name is Matt. I am a papillary thyroid cancer survivor since 2012, living in Seattle, Washington. And you're here for an update on trials for thyroid cancer in Australia, which is not Seattle, Washington. And we're here with Dr. Bruce Robinson. Dr. Bruce Robinson is an endocrinologist and professor at the University of Sydney in Sydney, Australia. He has been the head of the Cancer Genetics Unit at the Calling Institute of Medical Research, Royal North Shore Hospital since 1989. He has been chairman of Hoc Mai Foundation, a major program in medical and health education and exchange with Vietnam since 2001. In 2015, Dr. Robinson was appointed as chair of Australia's peak advisory and funding body for medical research, National Health and Medical Research Council. His research has focused on identifying genetic changes which either predispose or directly cause endocrine tumors, and among other highlights has been the formation of an international consortium of families from around the world to study medullary thyroid carcinoma and pheochromocytoma.
Great. Look, thank you, Matt, and good morning, everyone here in Australia, and good evening to our friends in America. Gary Bloom asked me to do this session in Australian time this morning, so as we could update some of our patients here in Australia about the trials that are currently ongoing here in this country, and also so that I could give you a little bit of background about how we got involved in clinical trials for thyroid cancer here in Australia. Many years ago, as Matt said in his introduction, we at North Shore became very interested in helping to understand the genetic basis for thyroid cancer. And in fact, when I returned from Harvard Medical School in 1990 to Royal North Shore, one of my fellow endocrinologists, Philip Clifton Bly, he had a couple of families with familial medullary thyroid carcinoma. And we set about trying to identify whether the children in those families actually also had inherited the gene which predisposed their parents to developing this particular cancer. That led on to us becoming part of the International MEN Type 2 Consortium, which led in 1993, actually a very short time after we started this, led in 1993 to the identification of the RET gene as being the gene which was causal in families with medullary thyroid carcinoma and multiple endocrine neoplasia type 2. The identification of the gene was undertaken by two groups, one in Washington, St. Louis, led by Professor Sam Wells, and another in Cambridge, led by Professor Bruce Ponder. So our role was to help provide families which enabled the identification of specific gene mutations in the RET gene in some of those families around the world. Very shortly thereafter, one of the major drug companies, at that stage AstraZeneca, was in the process of designing drugs which could inhibit the activity of the RET gene, which was turned on in these families because of the mutation that they had inherited. It was then subsequently established that not only was RET an important gene in families with medullary thyroid carcinoma and MEN type 2, but it was also very important in some patients with papillary thyroid cancer as well, because it was rearranged. And what that means is the RET gene was stitched onto another gene in the cancers of individuals, not in families, but in the cancers of individuals, particularly in individuals who had been exposed to radiation in the past. And you'll remember that in 1986, the nuclear reactor accident in Chernobyl occurred. And as a consequence of that, there were a number of children that 10 years down the track started to develop papillary thyroid carcinoma, a particularly aggressive form of papillary thyroid carcinoma. And it was found that those families, those individuals, I should say, had these RET gene rearrangements. So we had RET as a potential target for drugs in families and individuals with medullary thyroid carcinoma on the one hand, who had a specific abnormality within the RET gene. And then we had the potential for the RET gene to be also targeted in people with papillary cancer who had these RET gene rearrangements. And of course, once Big Pharma recognizes that there might be a gene target that can be tackled with a drug, they all started investing in trying to develop drugs that would be potentially of value in thyroid cancer. The first cab off the rank was Bandetinib, the drug that was developed by AstraZeneca. And Sam Wells, who I mentioned earlier, who had been involved in the development or the identification of RET in the MEN2 families, led some of those trials, and I led some of the other trials in individuals who had medullary thyroid cancer. And that was really the first major clinical trial in thyroid cancer that had occurred globally with a new drug agent. And we were fortunate enough to be involved in Australia in leading that trial for Australia at North Shore. The drug itself proved to be very effective at prolonging survival in individuals who had medullary thyroid carcinoma, some of whom were members of families with multiple endocrine neoplasia type 2. The drug not only was able to inhibit the RET gene, but it was also able to inhibit some other enzymes that were shown to be growth factors in thyroid cancer. And these enzymes are called tyrosine kinases. And so the group of drugs that was born really following Bandetinib is known as a group of drugs known as tyrosine kinase inhibitors, or TKIs for short. And there have subsequently been a number of these developed. Bayer developed sorafenib. I can't remember who developed sunitinib, but it briefly had an appearance in the management of patients with thyroid cancer. Then a drug company in the west coast of the US called Exelixis developed Cabazantinib. And then the most recent two drugs that have been developed are Selpercatinib, which was developed by a small startup company called Loxo Pharmaceuticals in Denver, subsequently sold to Eli Lilly for $8 billion. So clearly the companies who had made these early investments realized quite significant benefits from that early investment. And then the most recent drug, which has been in trial in the US, hasn't actually been trialed here in Australia, is Pralsetinib. The trial for that was led out of MD Anderson in Houston. So over the years, I'll run through, first of all, the trials that we've been involved with, then talk about the trials that are currently in progress, and then I'll talk about some trials which are currently being planned, both globally, and I'll also, of course, highlight those trials which are going to be able to be run in Australia to benefit Australian patients. And you might say to yourself, well, first of all, why do we get involved in these trials? And the answer is that these drugs are really the first group of drugs that have come along in over 50 years that can help people with various forms of thyroid cancer. In the case of medullary thyroid cancer, there was really no previous effective treatment other than surgery and radiotherapy. But with differentiated forms of thyroid cancer, these drugs have made an enormous difference to that group of patients, fortunately a small group of patients, who develop what's known as radioactive iodine refractory thyroid cancer. Because as all of you on the call would be well aware, most patients with differentiated forms of thyroid cancer, that is papillary and follicular thyroid cancer, do very well when treated with radioactive iodine, and many of those patients are long-term cures of their cancer. So it's really only that small group of patients with differentiated thyroid cancer who are people who one would consider as candidates for treatment with these drugs in the trial setting. Now, as a physician who looks after lots of patients with thyroid cancer, I was, of course, very keen to be involved in all of these trials, and that required many, many trips to the US because there is a saying, the squeaky wheel gets the grease. Unless you show up at all of these meetings, then of course you don't get to participate in the trials, and that means then that Australian patients are excluded from these trials. About 15 years ago now, I think it was, there was an organisation developed by a fellow called Dwight Vicks, whose wife Jean Vicks had died of medullary thyroid carcinoma. And Dwight felt that there was a real need to try to bring together people from around the world who were all trying to tackle thyroid cancer. He formed an organisation known as the International Thyroid Oncology Group. The International Thyroid Oncology Group, ITOG, is a member organisation. There are about 70 members of it at the moment. And it's formed really to try to bring together people who are interested in researching these cancers, but also to actually drive cancers that are not necessarily driven by drug company agendas. Whilst drug companies have played a critical role and lots of private investment has gone into supporting the trials, some of which I'm going to talk about today, we all felt that it was very important that we had an organisation that was run by physicians and surgeons and radiation oncologists that could actually make sure that the trials that were done, that were trials that were always in the best interests of patients, not necessarily those that were being designed with a commercial outcome as the end point. So ITOG has been a really important vehicle that's enabled me to have some of these trials developed in Australia, and I'm pleased to say that I'm now no longer the only member of ITOG from Australia. But I've been able to get Rory Clifton Bly accepted into membership of the organisation. Rory is an endocrinologist with me at North Shore and is also an exceptional human being. I always feel that it's important in any type of work that you do that you have a succession plan. So I felt that it was really important that I wasn't the sole person who was a member of ITOG. Anyhow, to come back to the trials, as I said earlier, the first of these trials that we got experience with, because I was not previously a clinical trialist until about 2002, when we started planning the Bandetinib trial, was the trial of Bandetinib in patients with medullary thyroid cancer. We did two trials. One was in patients with sporadic medullary thyroid cancer, and then another using a lower dose, 100 milligrams of Bandetinib, was done in patients who were members of families with multiple endocrine neoplasia type 2. And during the course of those trials, we gained experience with the tyrosine kinase inhibitors. We started to realize that these were drugs that were not without side effects, but they were drugs nonetheless that appropriately managed could provide patients with quite a decent extension of life and also quite reasonable quality of life if we managed the dose. We saw a number of toxicities which have become recognized now as being toxicities which do occur in pretty much all patients who are treated with this group of drugs, and the major one of these is fatigue. Some people describe that fatigue as overwhelming, but as I said earlier, we've learned that if you reduce the dose of drug that you have patients on, or alternately, we give patients what are known as drug holidays. So every few weeks, we give them 3 or 4 days off drug. They're able to recover and then recommence again, sometimes at a lower dose. So Bandetinib was the first of these trials. The second was the drug Cabazantinib, which again was trialed in people with medullary thyroid carcinoma. You'll understand that many of these drugs, because of their ability to target RET, were first trialed in patients with medullary thyroid cancer, and it's only been subsequently that they've been trialed in patients with radioactive iodine refractory differentiated thyroid cancer. Cabazantinib was another very good drug. It caused some cardiac abnormalities. We had to watch carefully that people didn't develop ECG abnormalities during the time that they were on Cabazantinib, because those ECG abnormalities could potentially be fatal, and we learned how to monitor those ECG abnormalities and then reduce the dose if we started to see any change in the ECG. Again, very good responses in patients treated with Cabazantinib who had medullary thyroid carcinoma, with significant prolongation of what is known as progression-free survival. Then the drug that arrived that really was a bit of a game changer was Selpercatinib, also known as LOXO-292. That was before it was named Selpercatinib. And don't ask me in the questions why these names are given to these drugs. Many of them are tongue twisters, and it's only after you've been using them for a while that you get used to them. So Selpercatinib was a game changer because it was much more specific. That is, if you can imagine tyrosine kinases as a bit like locks in a door, the thyroid cancer cell has a number of different locks on the outside surface of each cell. And the one that we really wanted to inhibit was very specifically the RET receptor, or the RET lock. And Selpercatinib was really the first of the more specific tyrosine kinase inhibitors. So it didn't touch all of the other tyrosine kinases in the same way. And so we got a much narrower spectrum of side effects and a much more effective value from the drug itself. The Selpercatinib study was run by Dr. Laurie Wirth from Mass General, and there were centers from all around the world, Eastern Europe, North and South America. We actually had a site in China and India as well. And of course, we had sites in Australia. And one thing that we have tried to do as we've gained more experience with these drugs is expand the use of them outside of the group at Royal North Shore in Sydney. And so we particularly got Professor Duncan Topless from the Austin Hospital in Melbourne, and also Professor Don McLeod from Royal Brisbane Hospital to be involved in the Selpercatinib trial. The first Selpercatinib trial was in patients, three groups of patients really. The first was patients with medullary thyroid cancer. The second was a group of patients who had RET gene rearrangements in their lung cancers, and that was run out of the Peter MacCallum Cancer Institute in Melbourne. And the third group of patients, and this group is still open in this trial, is patients with differentiated forms of thyroid cancer who had the RET PTC rearrangements that I've spoken about before, that particularly occurred in people after they had been irradiated, although we don't see them exclusively in that group of patients. So now part of the workup for all patients who have thyroid cancer, certainly all patients with medullary thyroid carcinoma, is to do a genetic screen of their tumor to see whether it actually contains a mutation in RET. And if it does, then patients can be treated with Selpercatinib, and I'll talk about how that can happen now. And if it doesn't, then they have to be treated with one of the more broad spectrum tyrosine kinase inhibitors, such as Cabazantinib. So this current study, which is open here in Australia, is known as the JZJB study. And that is the one that I've just referred to, which has three main groups of patients. Initially, there was a dose escalation study. So in those sort of studies, patients in groups of three are treated with a certain dose of drug, and if they all do well and don't develop terrible toxicity, then the dose level is increased until you reach a point when all of these three patients start to develop side effects, and then you usually back off one level of dosage, and that becomes the dose that's used in all subsequent studies. And that was exactly what was done with Selpercatinib. So we gained a lot of experience with Selpercatinib, and the Selpercatinib study was published in the New England Journal in, I think, June last year. And really a major milestone study in the treatment of patients with radioactive iodine refractory thyroid cancer and also patients with medullary thyroid cancer. And in the medullary thyroid cancer group, we saw very significant prolongation of survival as a consequence of treatment with that drug. The drug trial has now finished for the patients with medullary thyroid carcinoma. So that's not available in Australia on trial, but Lilly, who bought Loxo, have an expanded access program opened. So this is a program where patients can receive selpercatinib, and in response, and if they receive the drug, they have to agree to be followed and to be seen by a physician every few weeks, just to make sure that in the real world, if any side effects to the drug develop, we note them, and that then is used by the company as part of its application to the regulatory authorities to ensure that all of the side effects that can occur with these drugs are properly documented. Selpercatinib is now licensed for the treatment in medullary thyroid cancer in the US. It's not licensed for treatment in Australia yet, but the company is in the process of getting a dossier together to apply to the Therapeutic Goods Administration to have the drug accepted in Australia. And then the next step, of course, would be to try to get it onto the Pharmaceutical Benefits Scheme so that patients received drug that was subsidised down to the level of a PBS script, which is about $50 these days. So at the moment, the way patients access selpercatinib in Australia is through the Expanded Access Program, or they can access it through another study that Lilly is running, comparing selpercatinib with either Bandetinib or Cabazantinib. And that trial has been slow to recruit. It's actually a good study. And the reason it's been slow to recruit, though, is that, of course, patients would rather try to get access to the drug on the Expanded Access Program rather than run the risk of being randomized to receive one of what they possibly consider to be inferior drugs, i.e. Bandetinib or Cabazantinib. I'm not sure that they are actually inferior drugs, even though the spectrum of tyrosine kinase enzymes that they inhibit is different to the relatively targeted tyrosine kinase inhibition that you get with selpercatinib. It may be that in the long run, some patients will do better with that broad spectrum inhibition of those enzymes rather than with the very targeted inhibition of RET, which selpercatinib is able to achieve. In that trial, patients are randomized to receive either selpercatinib on the one hand, or if they get randomized to the control drug, the control drug is chosen by the physician at the site where the trial is being run, so either in Melbourne, Sydney, or Brisbane, and the physician gets to choose for the patient whether they receive Bandetinib or Cabazantinib. And the study is then comparing how patients go on those on either of those three drugs. And of course, if they are randomized to receive Cabazantinib or Bandetinib, then these trials ethically these days have to be structured so that patients can swap out of the Cabazantinib Bandetinib arm of the study and onto the drug, which obviously the company thinks is going to prove to be superior. So overall, it's still a pretty good deal for the patient. And one of the things that I suppose I keep reminding Greg Hunt, our Commonwealth Health Minister, about is that these drug trials mean that patients' care is fully funded by the pharmaceutical company. So none of the scans that people have, most of the visits to see the doctor that the patients have, all of the pathology that the patients have when they're on these studies, that is all covered financially by the drug company. And they even pay for patients to be flown in to the centres. We have a lot of people who come in from Sydney Until COVID, we had people flying in from New Zealand. All of the costs of that travel, the accommodation associated with it, was covered by the pharmaceutical companies. So when people are critical of big pharmaceutical companies, particularly critical of the cost of the drugs that they sell subsequent to these trials proving them to be effective, what they sometimes, I think, fail to recognise is that there's been a massive investment in getting the information that enables the drugs to become registered in the first place. And some of the way that money is spent is on having patients not have to pay to participate in these trials. So these trials have been a terrific boon to us here in Australia, because now we're able to offer patients treatments when either there weren't other treatments in the case of medullary thyroid carcinoma, or we're able to offer them treatments when they've failed radioactive iodine treatment in the case of papillary and follicular thyroid cancer. We've also been able to use these drugs in a slightly novel way. We occasionally see people, usually half a dozen, maybe 10 patients a year at North Shore, who have what is known as poorly differentiated or anaplastic thyroid cancer. These tumours are usually rapidly progressive. They may wrap around the larynx and the vessels in the neck, and ultimately, in the past, have killed people usually within weeks to a few months. They are particularly lethal tumours, and often ones that surgeons are even reluctant to operate on, because patients often succumb as a consequence of the quite extensive surgery that needs to be done. Patients may need to have laryngectomies done, taking out the larynx so they can't talk. These are major surgeries, and not surprisingly, not necessarily appropriate surgeries for a lot of patients. We've found that we're able to use some of these drugs, particularly we've used Bandetinib and we've used Selpercatinib on one patient, to actually shrink these tumours so that they then become surgically operable. And in fact, I have one patient, I received a call during the patient's operation from a surgeon, a very good surgeon at the Sydney Adventist Hospital, to say to me, look, he was halfway through this operation and he thought that he couldn't get the rest of the tumour out. What did I suggest he did? Here's a surgeon asking a physician for advice in the middle of an operation. It's almost unheard of, as you would all appreciate. But the surgeon is a great guy, a very good surgeon, and realised that he was in a tight spot. So we recommended that he stop the operation, leave the remainder of the tumour in situ. We then saw the patient and started the patient on treatment with Bandetinib. That shrank the tumour on the other side of the patient's neck, and the surgeon was able to go in 6 weeks later to remove the remaining tumour in the neck. We then were able to scan the patient to see that they actually had multiple metastatic lesions in their lung, and that not only were there multiple metastatic lesions, but these metastatic lesions actually took up radioactive iodine. So here's a patient who's really been saved because of these drugs. His tumour was able to be shrunk, previously inoperable, and it's subsequently shown that the rest of his tumour was actually still sensitive to radioactive iodine. He had radioactive iodine and he's alive and well 2 years later. So this is another way these drugs have been able to be used to good effect in patients who would previously have been pretty much told to go and get their affairs in order. And in fact, just last Christmas, I received a phone call through the hospital switchboard from a patient in Rockhampton who'd been told just that. The surgeons in Rockhampton and the surgeons in Brisbane basically said to him that there was nothing that could be done. He found our group at North Shore through Facebook page. He had medullary thyroid cancer, came to see me. I had him see Professor Lee Delbridge, who did feel that he was able to operate on him. He successfully operated on the guy. The guy is now on the trial that I mentioned to you, comparing Selpercatinib with Bandetinib and Cabazantinib, and he's doing very well. Fortunately, we've been very lucky at North Shore. All of our patients have actually been randomised to receive Selpercatinib, as it's turned out, and he's doing very well on Selpercatinib. and is alive and well with good control of his disease. It hasn't gone away, but it's still controlled. He's now retired from his work as a coal miner, and he is enjoying retirement with his wife and family. So another example of how these drugs have really transformed the options that are available for a patient such as this. Now, they are the trials that are currently going at the moment, but I will spend just a couple of minutes talking to you about one new trial which has been started or is about to be started here in Australia. One of the things that was recognised as we began to understand more about thyroid cancer was that there were a number of genes, the activation of which was actually critical to the development of these cancers. And one of them, there's a pathway or two pathways that exist in a lot of thyroid cancer cells. And one of the second messenger systems, one of the internal working molecules of the lock that I've been referring to, that's so critical in these cancers, is an enzyme, again, called MEK. And people at Sloan Kettering had done some work about 5 years ago. Jim Fagan's group had done some work with a drug called Selumetinib, which it was thought might be effective in inhibiting the MEK molecule and turning people who had run out of the ability to suck up radioactive iodine into their tumours to turn that ability back on again. So these MEK inhibitors could turn on the little sodium iodide pump on thyroid cancer cells and turn them from being radioactive iodine unresponsive to again being radioactive iodine responsive. Now, the initial trial of selumetinib ended up being abandoned because there weren't enough people in the trial who actually had their little sodium iodide pumps turned on, unfortunately. But it's now recognized that there are a number of other molecules that can inhibit this same enzyme, MEK, and one of them is known as trametinib. Trametinib has been used in some people with thyroid cancer who have failed to respond to radioactive iodine, but it hasn't been used previously to turn on the sodium iodide pump in the thyroid cancer cells. So Andrew Scott at the Austin Hospital in Melbourne pulled together a group of clinicians largely on the east coast of Australia in Brisbane, Sydney and Melbourne to develop what is known as the iFirst trial. And I can't actually tell you what the acronym stands for, but this trial has been funded through the Medical Research Future Fund here in Australia. The Medical Research Future Fund was set up by Tony Abbott and Joe Hockey when they were the Prime Minister and Treasurer, respectively. The Medical Research Future Fund is an endowed fund which contains $20 billion, and the interest on that money has now become a major source of funding medical research in Australia. And it's designed to fund what is known as translational medical research. So medical research, which is not basic stuff, but research where we already know a lot and we want to try and get it quickly into the clinic. And so Andrew pulled together a group of people, and I'll give him great credit for this. He was the mastermind of this. He's a nuclear medicine physician at the at the Austin, and this fund provided $3 million to enable this trial to be developed. And the ethics committees are currently being bombarded around the country with applications for us to be able to get this trial up and running in the new year. The aim of this trial, which is an Australia-only trial, is to redifferentiate, that is to turn on the sodium iodide pump on the cancer cells of people who have lost the pump's activity. And if we can do that, we'll be able to make radioactive iodine, again, a treatment for them. Obviously, the group of patients in whom this trial will be done are people who have failed radioactive iodine in the first instance, or who have failed one of the tyrosine kinase inhibitor drugs, such as Bandetinib, which is on the PBS here in Australia. So this is a very important study to be done in Australia, and I think it would not be able to be done had it not been for the fact that we had developed significant expertise in running thyroid cancer clinical trials here in Australia, and that we had clinicians who were comfortable doing that on their patients, because you understand clinical trials of cancer drugs have traditionally been done by oncologists, and these trials are now largely being run by endocrinologists like myself, or nuclear medicine physicians, with some oncologists starting to become interested in them as well. So the iFirst study is going to be run, as I've said, in Sydney, Melbourne, and Brisbane. And also there is a site almost certainly going to open up in Adelaide and hopefully in Perth as well. That's if Perth is still part of the Commonwealth of Australia. You all understand what I mean by that. So the iFirst study is a new study for Australia. There is a similar study being developed by ITOG in the US using selpercatinib to again try to redifferentiate people's thyroid cancer, but that trial unfortunately can't be done outside of the US. So fortunately we've got our own redifferentiation study happening here in Australia that Australian patients will be able to participate in. And then the other trial, which is in very early development, is Lilly have a new drug which they want to do a phase 1 study of, and we've been approached at North Shore to participate in that. A phase 1 study is one where we essentially have to prove the safety of the drug, and it's one that's designed, as I mentioned earlier, where everyone gets the drug, but 3 patients get 1 dose, and then another 3 patients get a higher dose, and gradually we creep up the dose until we reach a point when the people on the highest dose start to get side effects, and then we back off. We then know that that's the dose of drug that needs to be trialed in what's called a phase 2 study, where some patients receive a control drug and some patients receive the real trial drug. So that's a study. The phase 2 study is one that will probably be at least 2 or 3 years away. Unfortunately, because of COVID, we haven't all been able to travel as much to meet with colleagues and to plan these trials in the way that we have planned them in the past. Often the idea for a trial occurs over the dinner table at a cancer meeting, whether it be the European Thyroid meeting or the American Thyroid Association meeting, or one of the ITOG meetings. That's where the ideas for these trials and the trial management group generally gets put together. So it's important that we from Australia are able to get to these meetings so that we can become investigators on the trials and thereby provide access to Australian patients to these drugs, when they're still at a trial stage. Because of all of the drugs that have been trialed so far, the only one that has actually got onto the pharmaceutical benefits scheme is Bandetinib for differentiated thyroid cancer. We still don't officially have a drug on the PBS for patients with medullary thyroid cancer. And so it's really important that patients with medullary thyroid cancer do get access to the clinical trials of drugs like selpercatinib, comparing it to Bandetinib and Cabazantinib, because that's really the only option that they have at the moment for the management of their thyroid cancer. So look, I might stop, I think, at this point. That's been enough talking, but I wanted to give you a little bit of an understanding of the history of our involvement in thyroid cancer clinical trials, what's current and what is planned for the future, because there will be more of these drugs. There's clearly opportunities for investment by big pharmaceutical companies in this disease, and it's very important that we in Australia are participants in those trials, because that's the only way patients in Australia will initially get access to this early treatment, and then eventually there will be evidence that will enable them to go more broadly onto the pharmaceutical benefits scheme. So thank you. And I think, Matt, you were going to try to deal with questions and then feed them to me rather than me getting them out of the chat room.
Well, as of right now, we only have one question, and the user was a teenager in Sydney in the early 70s when the French were setting off bombs in the Pacific.
Yep.
and they weren't allowed to drink milk or eat vegetables for months. And 19 years ago, they were diagnosed with papillary. They felt their cancer was a result of the fallout. Are you seeing any patients in Australia that you think is the result of the French bombs? Should I be correct about the cause of my cancer?
Yeah, okay. So look, thank you for the question. We get asked this question not infrequently. The answer is we've not seen enough patients with papillary thyroid cancer who have the RET PTC rearrangement that I referred to earlier, the one that occurred around the Chernobyl nuclear reactor accident and which is beginning to be seen around the Fukushima nuclear reactor accident as well. We think that we were far enough away from the fallout for it not to have really caused any appreciable damage to the thyroid gland here in Australia. Most of the patients who we see who have radiation-associated thyroid cancer are people who have had extensive dental work, which was unshielded. So you know now when you go to the dentist and they want to take an X-ray of you, they put on a collar that covers your thyroid gland. And if they don't, you should get up out of the chair and walk out. So most patients have a proper protection when they go to the dentist. And then the other group of patients who develop papillary cancer are patients who've had radiation for lymphoma, particularly Hodgkin's disease, or alternately, many, many years ago, patients received radiation of the skin if they had bad acne. Generally speaking, that group of patients is now well into their 80s because it was recognized a long time ago that that was actually really dangerous treatment.
We have another question. Do you think mobile phones are a danger to the thyroid gland?
No, I don't. No evidence whatsoever for that.
Looks like we have another question. Are these trials applicable to poorly differentiated thyroid cancer? Have any poorly differentiated thyroid cancer patients participated in the trials?
Yes, the answer is very definitely yes to both of those questions. We have a number of patients with poorly differentiated thyroid cancer who are now being treated with Bandetinib because nearly all poorly differentiated thyroid cancers contain different areas of cancer, some of which are very responsive to radioactive iodine and others which are not. So Bandetinib is the most widely used drug for this group of patients now. But increasingly, we are seeing those patients also be able to participate in some of the trials of the newer drugs as well. So yes, very definitely, this group of poorly differentiated patients are very suited oftentimes to treatment with this group of drugs.
Great. And is there any other questions? Doesn't seem like there is. So with that, I guess we'll end the session early and give you back your morning. Oh, we got one more popped up last second. Do you see a difference between monotherapy and co-therapies? Co-therapies, maybe?
Yeah, I think that's probably, yeah, okay. I think I know what the questioner is asking.
Oh, combo therapy, sorry.
Combo therapies, yes. There is actually a trial that was run by ITOG looking at the combination of Lenvatinib and pembrolizumab, the Keytruda, the drug that's used for melanoma predominantly, but it's an immune therapy drug. And it's the drug that Jimmy Carter, the former US president, is on for his metastatic melanoma. So the combination was slightly better than Lenvatinib alone in that study of Lenvatinib plus pembrolizumab. So yes, we have some patients who have been treated with both drugs, but the benefit is only very marginal. And of course, the side effect profile of two drugs is usually worse than the profile of just one drug. So we would consider using it. It has to be self-funded, unfortunately. The Lenvatinib part of the combination is funded through the Pharmaceutical Benefits Scheme, but pembrolizumab is not on the PBS for thyroid cancer at the moment.
How do we participate in the clinical trials?
Well, the first thing is to be evaluated as to whether you're an appropriate person to be in the trials. And to that end, you have to generally have fairly extensive disease, and disease which is able to be measured on a scan, because of course in all of these trials we have to try to measure a response, and so you have to have something that can be measured on a scan to see whether it's getting bigger, smaller, or staying the same. So generally speaking, you have to have relatively advanced disease, whether it be medullary or differentiated thyroid cancer, or even poorly differentiated thyroid cancer, and we have to show that it's progressing. So we have to have scans that are generally within 13 or 14 months of one another, showing that there is an increase in the size or bulk of tumor that a person has. And unfortunately, we sometimes get sent people who haven't had that earlier scan. We do a scan on them and they've got a large amount of disease, but they don't have a previous scan with which it can be compared for us to be able to say they have progression, and therefore they can't get into the trial. We then have to wait another 4 or 6 months where we can do another scan to show that progression before they're eligible to get into the trial. And that's always a shame. It's a heart-wrenching 3 or 4 months for the patients because they feel as though they're missing out on something, and they are. So, yeah, make sure you get seen by a good endocrinologist who knows that progression is required for entry into these trials. And secondly, many of the trials now require molecular profiling of tumor tissue so that a mutation has to be evident for you to get into the trial as well. So make sure you get your tumor tissue analyzed genetically. I think these days, certainly with medullary, it should be done at the time of diagnosis. And if you have papillary thyroid cancer or follicular thyroid cancer, you don't necessarily need to do it at the outset, because most papillary thyroid cancers and follicular cancers react favorably to radioactive iodine. But if it stops reacting to radioactive iodine quickly, you need to get your tumor tissue analyzed to see whether it might have any of these particular mutations in it.
Can you comment on the use of everolimus
Yeah.
with Lenvima as a dual therapy?
Yes. So we have recently used that in one patient. Unfortunately, toxicity, I think, became a reason for us to have to stop it. We've only used it in one patient so far, and that patient had genetic analysis done at Foundation Medicine in Boston to suggest that that combination might have been useful, but in the end, I think it proved not to be. So very early data suggests that everolimus may be of some value, but it hasn't been extensively studied in large trials like the tyrosine kinase inhibitors have.
Are you optimistic about future treatment with immunotherapies? Is there any research about immunotherapy in Australia?
There's a little bit of work being done on CAR T cell therapy, which is an immune therapy at the Peter MacCallum Cancer Institute in Melbourne. That's really the only immune therapy that I think is likely to be significantly valuable in people with this type of cancer. And the reason is that thyroid cancer is unfortunately not a very immune reactive tumor, unlike melanoma, for example, which does generally respond very well to immune therapy. So I don't have enormous hope that drugs such as pembrolizumab, the PD-1 inhibitors, will be of great value in thyroid cancer. I think it will take other sorts of immune therapy for us to tackle it from an immune point of view.
Is my understanding correct that inhibitors only assist in prolonging life, but it does not reduce tumor size?
Certainly they can assist in prolonging life. They won't cure people, but they are often very effective in reducing tumor size. As it was in the two examples that I mentioned earlier, of patients who had big inoperable tumors that were able to be shrunk with these drugs, and as a consequence, were able to then proceed to have them surgically removed. So yes, they can be very effective in reducing tumor size.
Could you repeat the name of the gene rearrangement again? Something about RET-PT?
Yeah, it's RET-PTC, RET/PTC.
Okay. And what is the relationship between pituitary gland and the thyroid gland?
So as you know, in normal people, the pituitary gland sends out a signal called TSH to the thyroid gland to make it produce thyroid hormones, and then the thyroid hormones feed back onto the pituitary gland to turn off TSH. So there's an inverse relationship between TSH and thyroid hormone levels. One of the mainstay components of the management of patients with thyroid cancer is to try to turn pituitary TSH off, because TSH, as you know, stands for thyroid stimulating hormone, and we don't want it stimulating any little thyroid cancer cell that might be lurking in a lymph node or somewhere in a patient with thyroid cancer. So we tend to have slightly high levels of thyroid hormones in the blood in order to turn off TSH.
If a patient has a cousin that had Rathke's cleft operated on, and now they have thyroid nodules, should they be concerned?
No, not really. There is a very vague embryological relationship between Rathke's cleft and cysts of Rathke's pouch cysts, but not one that should be concerning, no.
And I think this is the last one. When I speak to my Japanese colleagues, breast cancer in Japan, for example, is diagnosed in very young women in comparison to older women in the United States. Can you comment if you have noticed such a trend in thyroid cancer in Australian and New Zealand patients versus European, US, or Japanese patients?
Yes, I can comment that we have not noticed such an age-related earlier diagnosis. What we have noticed, and John Burgess from Hobart has written about this extensively, is that the incidence of thyroid cancer is rising in Australia just as it is rising in other parts of the world as well, particularly North America and Europe. We think a lot of that increased incidence is not necessarily due to background radiation, but just due to increased diagnosis, because more and more people are having ultrasounds of their neck, and they're finding tiny thyroid cancers much earlier than they would have ever been found before. And in fact, some of those thyroid cancers were probably never going to cause any major problems for people. So yes, the incidence is rising. It's not age-related, and the cause is probably just greater diagnostic power.
Okay. And with that, we thank you, Dr. Robinson, and appreciate your talk today and answering all these questions. Thank you for everybody that came to the session and asked those questions, and hopefully we'll see you next year. And
in person.
I would love that. And that will call this to an end.
And you could even run a ThyCa conference down here, Matt.
Yeah, I'll talk to Gary about that, see what we can arrange.
Well, talk to Bev. She's always keen to organize things like that.
All right.
All right. Take
Nice to
care.
meet you.
Thanks all. Bye-bye. Bye.
Thank you. Bye-bye.
Bye.